thank you for having me today. In this presentation, I'm going to give a brief overview of our needs-based planning for mental health services in Australia and how it's informed our National Mental Health Workforce Strategy. Firstly, I'd like to acknowledge the traditional owners of the land I work from, the Yagara and Turrbal peoples, and pay my respects to their elders past, present, and emerging. I'm going to start with some policy context and an overview of how we conducted a mental health workforce gap analysis for the national strategy. And then I'll touch on some of the challenges, the successes, as well as some potential learnings for Canada from this work. So development of a 10-year national mental health workforce strategy for Australia for 2022 to 2032 started off in 2020, led by the federal government. And there's been an increasing focus in Australia for a number of years on mental health and suicide prevention and the need for coordinated system reform. So in Australia, a lot of this focus has been supported by the role of the federal government in managing primary mental health care and in coordinating and driving national healthcare planning and funding in collaboration with all of the states and territories. But in addition to that, in 2020 to 2021 particularly, there were a number of key prominent reports and inquiries around mental health, including a National Productivity Commission mental health inquiry and various other national and state reviews of the service system as well. And these inquiries and reports repeatedly highlighted some of the service gaps and made recommendations about supporting system reform, including the need for a skilled workforce to underpin expansion of those mental health services as well. And then on top of that, with the COVID pandemic, we also had a strong focus from all levels of government on supporting population mental health, particularly during some prolonged and ongoing lockdowns as well. So leveraging all of this, the National Workforce Strategy was kicked off with a national task force to help guide the work and a series of consultations and various data analyses to help develop the new strategy. And my research group has been leading work on needs-based mental health planning for a number of years. And for this strategy, we completed a project to analyse the current workforce capacity versus the estimated workforce that would be needed to deliver good mental health services. So to start with, to estimate the total mental health workforce need, we use the National Mental Health Service Planning Framework. So the framework is a needs-based planning model for Australian mental health services that quantifies the total mental health needs in the community and then estimates the workforce and other resources required to deliver that evidence-based care to the population that needs it. And it draws together best available data and literature and expert consensus as well to look at the epidemiology for mental health, looking at best practice service models, the types and the quantities of different care that would be needed for different populations with mental health needs, and then estimates the full-time equivalent workforce needed to provide that care. And so it's similar to needs-based planning models for mental health and substance use services that have been developed in Canada as well. And the framework is being used widely in Australia to support mental health planning at national, state, and more regional levels as well. So for this workforce analysis, we use the full-time equivalent workforce targets from the framework by different provider types and different service sectors, as well as the target population age group and the rurality of those populations as well. And we looked at workforce needs for the most current year of data that we had for the current workforce, which was 2019 at the time, and also projected forward for population changes to the workforce needs in 2030 as well. And I should just note here that the framework has a focus mainly on mental health services and doesn't include substance use treatment services, and that the workforce strategy for mental health was also focused on mental health care services as well. So once we had the estimates of the workforce needed, we also wanted to compare that to the actual supply or capacity of the workforce at the time in 2019. And so we used a few different data sources to try and cover the range of providers and services here. And we started with a quick analysis in the first couple of months of the project using the National Health Workforce Dataset. So this is a dataset on regulated professionals, such as doctors, nurses, psychologists, and occupational therapists. And they're surveyed every year and provide some information on their working hours and their areas of practice as well. So this was a really useful starting point. It gave us a lot of information, but it also misses some important workforce areas, as you've probably thought about, like social workers, counsellors, and psychotherapists, who are not nationally regulated professions in Australia, as well as mental health support workers and lived experience workers in non-government services as well. So we did want to explore more into those areas and also into some of the different sectors of the mental health system and target populations as well. So we did a further analysis for about another 6 months after the initial workforce data set, where we were able to bring in some additional data sources from routine data collections, which included the full-time equivalent salaried mental health positions working in state-funded specialist inpatient and community services. And in addition, we had some billing data or activity data from primary mental health care services through Medicare and also through our National Disability Insurance Scheme. And we supplemented that with a few other smaller estimates as well. And so drawing on those data sets, we focused on the full-time equivalent capacity in terms of the amount of care that can actually be provided and on clinical care hours or the actual hours of care rather than just administrative positions. And where we had activity data or insurance-based data, we used our best estimate of the hours of care delivered and converted that into a full-time equivalent based on assumptions around how many hours of care can be delivered per workforce per year. For some roles like nurses and occupational therapists, we had some information about whether their focus area was mental health. And we also tried to estimate that for general practitioners by looking at some data on the proportion of time that they're likely to be spending on mental health related care as well. And I guess one of the issues with potentially cobbling together a range of these data sources was that we were possibly going to be double counting professionals across, like, say, the registration data versus the services data sets. So for each of those areas, we chose a best estimate based on which data source was likely to have the best coverage and be most robust as well. So this graph is an example of some of the key results out of our analysis. And the light blue bars on the left show the estimates of current workforce supply in 2019. And then the two darker bars on the right-hand side are estimates of the required workforce. So the darkest bar is for 2019, and then the further gap scaling up to workforce needs in 2030 as well. And on the left, you can see that we had a range of estimates available. So for GPs, psychiatrists, nurses, psychologists, OTs, social workers, various types of mental health support workers and peer workers or lived experience workers as well. But there were some data limitations. So for example, the only data we had on social workers and OTs separately was in those state salaried positions, and for primary mental health care, the billing items don't distinguish between what type of provider it is. So we had to combine that category to get a best estimate. And the framework targets for the workforce are also not super prescriptive about exactly which profession needs to deliver a certain type of care. So for example, the estimate here around psychologists is actually an estimate of the workforce required to deliver structured psychotherapies. And it's possible, for example, that there might be other professions that could be leveraged or be suitable to deliver those types of services as well. So you can see if we look at the total bar for the whole workforce at the bottom, that there were gaps identified overall quite a bit and also across a range of different professions. And the largest percentage gaps were for our lived experience peer workforce, Indigenous mental health workers, and also for psychologists, where there were significant shortfalls in the current workforce. And then if we look at the overall FTE gaps in terms of total number of full-time equivalent positions, the largest absolute gaps there were for the mental health nurses, for psychologists, and for peer workers as well. So what were the challenges? Well, as I've talked about a bit, we did have to draw on a number of different and incomplete data sources to estimate the current workforce. And because our social workers and the counsellors and psychotherapists are not regulated professions in Australia, it was much more difficult to estimate those workforces than some of the others. And there were some things like some data on the head counts for the number of counsellors available on various websites, but that doesn't tell us a lot about their working hours or how much capacity they actually have to deliver care. So we were really interested in trying to estimate full-time equivalent available workforce as well. We also had to use best estimates and modelling to account for limitations of some of the data sources and overlaps across different aspects of the data, as well as trying to estimate the amount of mental health related care delivered by some of those generalist providers like GPs as well. And we had particularly difficulties with getting some data around the workforce on psychosocial support in the non-government sector. So although that's a really critical part of our mental health workforce, there are no national or standardised data collections for those services in Australia. And we had some data available and made some estimates, but it was definitely more limited and more unreliable than our clinical professions as well. Okay, there were some successes though. So even though we did have some data limitations to work with, we were still able to fairly quickly produce a national workforce gap analysis. And having the needs-based planning model was really important part of that process because it gave us actual targets for how much workforce we're likely to need and where we sort of need to be heading to support people with mental illness. And although we might get some of this sort of information about workforce shortages from talking to people in the sector, having the hard numbers and having those gaps clearly laid out is really powerful and really useful for informing policy as well. The workforce strategy did include a summary of our results, and alongside other consultations did highlight a lot of those key gaps that I've talked about. And since the strategy was finished, there have already been a number of strategies and funding that's emerged out of that as well. So there's a National Mental Health and Suicide Prevention Agreement that's happened and since been endorsed by the federal and state governments, where they have all agreed to work in partnership to address these critical workforce shortages and to also work on improvements in data collections around mental health services and workforce as well. And the federal government has already made a number of major funding commitments to increase some of the pipeline for the workforce, and in particular, increasing the training places for mental health nurses and psychologists and allied health professionals, for psychiatrists, more support for our Indigenous workforce, and a lot of support to help to develop the lived experience workforce and look at peak bodies and other mechanisms to support developing and credentialing that workforce as well. So finally, briefly summarising some lessons learned. So firstly, we've had years now in Australia of highlighting a lot of the shortfalls in the mental health system, but without the workforce, it's difficult to actually scale up or further develop those services. So it's such a critical part of improving mental health care. And the strategy took the approach of thinking about different levels or layers of workforce as well. So although we can consider those mental health specialists like psychiatrists and psychologists as being kind of a central part of the workforce, there are also broader health and social care professionals who might be gatekeepers or have those touch points where there's opportunities to develop their knowledge and skills in supporting people in mental health care as well. In terms of data, there are real opportunities in Australia and in Canada too to draw on our existing needs-based planning models for mental health and substance use. So when we can actually identify the total workforce targets and how much workforce is actually needed to deliver good mental health care, it really allows us to think about how far we need to go or which areas need particular attention across the workforce as well. And then bringing together that existing mental health workforce data and services data does make it possible to at least estimate the available mental health workforce and where it's distributed. And from projects like this that I've worked on before, doing these kinds of gap analyses, it really is helpful to be able to lay out those actual numbers and percentages and shortfalls and areas that might be doing better or worse across different target populations or different workforces, different parts of the country as well. And this sort of analysis doesn't really need to be that complicated. Sometimes a quick and dirty best estimate using whatever publicly available data is around can get you like most of the way to doing the results, can get you some really good pictures quite quickly. And then it really just depends on whether there's feasibility and whether it's useful to sort of deep dive further and try to gather more detailed data or more peripheral data than what is readily available as well. And Canada might have a few different options in terms of data sources to what Australia does. So obviously it's going to look different on the ground, but you're also already ahead in some areas, like having more regulation around certain professions like psychotherapy that we don't have really any data on in Australia as well. The strategy and the actions that have come out of it have been really well supported by the federal government's role in planning and supporting that, but also by a lot of the collaboration and the commitments by each of the states and territories to try to work towards that agenda for reform as well. So it's been a really collective effort. And finally, our analysis has really highlighted some opportunities, I guess, to further try to build and improve some of those data systems, which is now underway, and also to consider how other workforces can be built and emerged, like the peer workforce and counsellors, to help support expanding mental health care as well. So just to wrap up, I've included a couple of links here to the strategy and to the planning framework as well. And please feel free to email me if you have any questions.